Good morning, everybody. At the outset, I'd like to thank Dr. Rohit for giving me this opportunity. I have recently enrolled as a scholar under his guidance on the topic of my, this thing is pediatric keratoconus. Do I forward it? Okay. So why is pediatric keratoconus any different from adult keratoconus? Because there are a lot of social and economic implications associated with pediatric keratoconus. It's very difficult to diagnose. There is poor compliance and follow-up. And often the parents are the ones who are in denial. They don't want to bring the child back to you if there is an evidence of keratoconus. I've seen patients coming after 4 or 5 years, which is advanced keratoconus, which could have been treated easily with a cross-linking. So that is why we sometimes come across patients like this with advanced keratoconus who have been treated elsewhere and just spectacle correction has been done, and this is how they land up in our clinic. This is again a patient with unilateral keratoconus, which can often be missed because the child never complains and he is seeing very well with the other eye till he comes for a routine examination or there is a slight blurring in the right eye, then you diagnose an advanced keratoconus. Considering all this, we did a small screening of patients, which was a prospective interventional study of 700 eyes of 350 children who had astigmatism of greater than 1.5. In this, we detected about 32 eyes of 22 children who were clinically or topographically proven keratoconus. And once we observed them, we found that patients who had a change or progression of keratoconus was found in 25 eyes, and they underwent accelerated cross-linking. And they were followed up on day 1, 1 week, 1 month, and 3 months. So in our study, the gender distribution was majority were females. The number of patients, the high risk factor was eye rubbing in our study. The best corrected visual acuity did not really show any change from the first day to the 90 days, but the cylinder showed a statistically significant drop. And the other parameters we looked at was the flat keratometry, the median keratometry, and the pachymetry, which showed statistically significant drop. The steep keratometry, though it showed a drop, is not significant. So in our study, we found that the accelerated cross-linking was safe and effective and improved the topographic pattern, stabilized the progression, and there were no major side effects. Why are we looking at a pediatric keratoconus in a different way? There is a lot of studies done, and some of them done by Leone and Hafezi et al. Have shown that the incidence of progression is much higher in patients with pediatric keratoconus. And not only that, like as we have seen, the way that the time they present is much more advanced than you see in an adult case. They are more aggressive, and we all know the rigidity is inversely proportional to the age, and their corneas are less rigid. And of course, the associated factors such as eye rubbing and allergies, which could make the progression much more. So there is a need for early intervention because we are looking at patients who are going to develop an anisometropia. So you need to treat their amblyopia, the pachymetry becoming progressively thinner, and the continuous, in spite of the treatment, some of them continue to rub their eyes because of the comorbid factors such as VKC and the progression of keratoconus, which can put them on the table for a DALC. So the special concerns, what are we looking at? When you look at a patient with a progressive keratoconus in an adult, we immediately jump in and tell them, but in a child, the concerns are many, particularly coming from the family and also in your case. The timing of treatment, what is the treatment protocol? We are discussing a lot about epi on and epi off. The management of comorbidities, because if you're not going to take care of the comorbidities, then again the patient is going to progress. And a simple thing like looking at the iPad, which most of the children have started doing, resulting in eye rubbing because of the dryness, has to be taken care of. The choice of anesthesia, and of course, most importantly, for the children who are in their age group where they are studying, going for exams, the management of visual impairment. So these are some of the studies which have shown that timing of treatment should be as early as possible on initial detection. And the study has been very surprisingly shown that just in about 7 weeks, there's been a progression from 2.6 to 5 diopters, which has to be taken into consideration, and the parents have to be counsel to bring the patient at least every 3 months to see for progression, because once you bring a child and detect a 5-year-old child with keratoconus, it's going to be very difficult to make the parents understand that he has to go through a cross-linking. So at least you ask the parents to bring them every 3 months, then it makes it more easier for you to follow up. And more importantly, look at what are the comorbidities the patient has. So it has been discussed ad nauseum that epi-off Dresden protocol as the standard, gold standard, and this probably would be the best method of treatment, but making the child lie down for 30 minutes is going to be much more difficult than doing an accelerated cross-linking where you can reduce the time. And so at least look at something like doing an accelerated cross-linking, because it will buy you some time. And also more importantly, we'll have to look for a need for retreatment and the treatment of allergic eye disease, VKC, and limbal stem cell protection, and simple lubricants, looking at immunomodulation in patients who have chronic allergy, and doing an immunology test, looking out for IgE, and all that has been discussed previously has also been brought into the management of pediatric keratoconus. So epithelium on or off, in my personal protocol, if the patient is progressing, has an advanced keratoconus, probably I would definitely do an epithelium off accelerated protocol. If one eye is severe, the other eye is just starting the keratoconus, I would do an epi off on the eye which is severe, and epi on the eye which is just starting to progress, so that it gives us some time, because you don't put the patient through a lot of pain. So though there are several studies which have compared epi-on and epi-off technique, and there are some studies which have shown that epi-off did not stabilize the cone as much as the epi-off did, and majority of the studies have shown that the stabilization has been there for at least 2 years, and then you may need to retreat these patients. So choice of anesthesia depends not only on the age of the patient, the cooperative ability, but also the mental state, because we do get a lot of Down syndrome patients with keratoconus. So depending on that, you decide whether the patient is undergoing a general or a topical anesthesia. The management of visual impairment, like I think one of them pointed out, that mini-scleral lenses have really changed the whole ball game, because they're extremely comfortable and they neutralize the cone much better, the quality of vision improves, and the care of the lenses is much easier, the parents can fix it, and this is what I advocate for patients who have an irregular cone, or patients who cannot be treated with spectacles. And again, the need to do an amblyopia treatment, the occlusion which has to be counseled. So most of the studies have shown that there is a definite improvement after cross-linking by the Dresden protocol. This reduction of Kmax by 1 to 2 diopters is stability and halting of progression, and 1 to 2 lines gain in the best corrected visual acuity. Of course, the most important thing that we have to tell them is that there is going to be some pain in the immediate post-operative period, as well as a haze which can disappear over a period of 3 to 6 months. And accelerated protocol has been tried out in several studies, and one of the most important studies we've done at Narayana Nethralaya shows that they found that in pediatric patients, accelerated protocol using 9 milliwatts for 10 minutes definitely had an excellent effect, and reduced the treatment time, and also made it much more comfortable for the patient. To combine whether you need to do a Topo-guided PRK with CXL, this is one of our patients with a 17-year-old male who underwent a Topo-guided PRK with CXL, and you can see the excellent result. So these sort of patients can be given spectacles instead of making them wear contact lenses. So that's the advantage of combining these treatment. And also Intax and CXL also has an advantage that it can stabilize the cone, and not only stabilize the cone, but also has an additive effect in reducing the spectacle error. So in summary, though keratoconus, there is a lot of difference between adult and pediatric keratoconus, early detection and close follow-up perhaps is the most important thing, and also taking care of comorbid conditions, counseling the patients, need for follow-up has to be emphasized. So the keys to success are early detection of keratoconus, early intervention, closer follow-up, and management of trigger factors. And in our hospital, any child which has a cylinder of more than 1.5 or or equal to 1.5, we screen them, do a topography and pentacam routinely, and surprisingly, we do pick up quite a lot of patients. And normally, we don't jump into treating these patients immediately, but we counsel them so that we see them every 3 months, so that we are able to pick them up very early before the visual damage occurs. Thank you.